So today I'm going to talk about chest imaging. Um, my hope is that we talk a little bit about ultrasound, a little bit about CT, a little bit about chest radiographs. Um, we'll record this lecture for everybody who's not here. Make sure that it gets uploaded to KOPI's YouTube channel. Um, so the case that we're looking at today was a case from the United States. It's a 60-year-old individual who had a history of alcoholism. Um, he presented tachypneic, tachycardic, and hypoxic. Uh, he got placed on a nasal cannula oxygen. He had a swollen tender leg. On exam, lungs were clear. His initial chest X-ray was clear. It didn't show any signs of pneumonia or aspiration. The blood work eventually showed alkalosis, leukocytosis, and the cardiac enzymes were slightly elevated. Uh, this case draws a little bit of focus on how cross-sectional imaging can be used, and we'll talk a little bit about that. So the learning objectives of this are very briefly to discuss the utility of a chest X-ray. But in addition to that, make sure that we actually have a good understanding of describing the differences between chest X-rays, so the differences between AP and PA. But also understand that a lot of radiograph has a lot of information, and it certainly does add to the assessment. And then we'll discuss quite a bit about cross-sectional imaging, both ultrasound and CT. Uh, and then we'll also talk a little bit about IV contrast and angiography. Um, so, um, first off, there are many types of chest pain that require imaging to rule in the diagnosis. Chest X-ray becomes a big portion of the workup for pneumonia, pneumothorax. It's certainly part of the workup for heart failure. We talk about types of chest pain that can kill people and types of chest pain that we don't want to miss in the emergency department. We also want to remember that CTs are very important and that pulmonary embolism, which is maybe the second most common cause of lethal or morbid chest pain, and aortic dissection both require cross-sectional imaging in order to confirm the diagnosis. Now, all of these individuals are treated uh, individually, and we're not necessarily going to go into treatment and management of these conditions, but diagnosis is certainly the first step in terms of trying to care for these patients. Um, so we're going to talk a little bit about how to confirm the diagnosis and what actually goes into it. First things first, emergent and urgent indications for chest X-ray are relatively broad. I would say in the emergency department, when we're talking about when we actually truly need a chest X-ray, um, we talk about getting a one view or a portable chest X-ray. You know, I've talked about this with some people in casualty at Ciliani. It's really meant to not move the patient. Unstable patients don't necessarily do well if we take them to imaging. So the hope is that if you have someone who's hypotensive and hypoxemic respiratory failure, someone who you can't oxygenate, a patient who's potentially in shock, or somebody who you've just intubated or placed a chest tube on, that they would get an emergent chest X-ray, preferably a one view. And the reason why is because you don't necessarily want a patient with these conditions to go to uh, to go to any imaging study. You want them to be able to basically get the test where they can be at the bedside. Um, Urgent tests are, a little bit different. This ensues that the patient is stable, maybe that they're ambulatory, and that they can get a two view instead. Whenever you can obtain a two view is better. This might be a patient who's hypoxic, who's dyspneic, who has an acute cough that you might be concerned for pneumonia, who's maybe febrile, maybe septic. Um, you also want it for patients who could potentially walk, who has a suspected sickle cell, COPD, or heart failure exacerbation. And the same remains true for routine patients too. Patients who can potentially walk to the chest X-ray, you want to make sure that they get a two view if they can. And we'll talk a little bit more about why that is. When you get a two view, you are talking about getting a PA anterior uh, chest X-ray. So if you shoot an AP, it's basically assuming that the patient is lying with their back against a radiographic plane rather than their chest. So usually this means that the patient is lying in bed and that the plate is behind them. This happens with a portable chest X-ray. Um, the AP does enhance some of the mediastinal and heart structures, making it difficult to assess for cardiomegaly, and it can also make the mediastinum seem thwarted. So if a patient has an AP radiograph, it would be hard to compare it to a PA. And the reason was because the PA will actually shoot everything and enhance things posteriorly first. So the X-ray travels posteriorly, which gets a better view of the cardiac silhouette and allows for a better view of the anatomy. It does require the patient to stand though. So when you're talking about how to get a chest X-ray, you want to make sure that you're talking specifically with your consultants or with your patient about getting a two view rather than a one view if you can help it. And one view should really be reserved for the patients who are unstable um, or those who cannot walk. Um, so, in general, we want to make sure that we keep a very considerate mind about what tests we're ordering and make sure that the one view is generally held for patients who are unstable. This is a quick example of what the difference is between the PA and the AP. The PA is shown here, um, and you can see the reflection. You basically can tell that there is a difference in the heart shape. Here we can see that the cardiac silhouette is made out pretty definely. You can see the mediastinum very well. You can see the highlight of the lungs. When you see an AP, the cardiac silhouette does kind of start to blunt a little bit. You can see over here, there starts to be loss of a little bit of architecture. This is the same patient, and you can make out the heart a little bit less well. You do you do also notice that when we're talking about creating PA and AP, that the lung fields also look different, that they look a little bit more shadowed, specifically towards the apices. Um, and that's just actually like how the radiograph is supposed to be taken. And it has a lot more to do about the angle of the x-ray. You can tell that the angle of the x-ray is slightly different between an AP and a PA, and how the clavicles are situated. If you're interpreting an x-ray and you don't know, or it's not labeled whether it's AP or PA, the first thing that you can actually do is take a look at the clavicles. In a PA, the clavicles will usually be angled, and the AP will usually be flat. So a portable chest X-ray is a very helpful thing. Sorry about that. Portable chest X-ray is a very important tool um, that should be used uh, mostly for patients who are, unable to tolerate walking. Um, it does require a certain type of machine as well as certain type of radiography plates. Um, it is usually reserved for patients who are unstable. And again, it also assumes that the clinician can discern the difference between an AP and a PA. It's something that the interpreting physician needs to know as to whether or not it is a PA or an AP radiograph. Um, and its utility is extremely important, but I would say it's about comparable or maybe even less comparable than something like a portable ultrasound machine in the right hands. And I say this because it can be used to identify acute pathology quickly, such as an acute abdomen. It can also be used for trauma, uh, but a portable ultrasound can also be used pretty astutely and can certainly also play a role in um, those types of patients as well. We'll talk a little bit more about that. So, what are the limitations to chest X-ray when you're comparing it to a cross-sectional image? The X-rays that we take when we're taking pictures of the chest, they're only creating silhouettes. Um, when we're comparing it to a cross-sectional image, the silhouettes are comparable to basically 3D representations of tissue. So when we create a projection that's a chest X-ray, it's only passing through density, so it's only measuring density in one plane. Or if you get a lateral radiograph, two planes. That's why it's really important to get a lateral radiograph because if you're skilled, you can actually tell um, a little bit more of the dimension of the chest. A lateral radiograph might be able to help you discern densities or infiltrates that might only be perceived otherwise in one plane. So it adds a humongous amount of view to the actual dimension of the interpretation. Um, but it has less utility than a plane radiograph. Certainly, even a two view has less utility than cross-sectional imaging. Um, because cross-sectional imaging can measure things in multiple planes, so it can create, instead of one, two-dimensional, three-dimensional space. And it can show you things in three dimensions. Um, when that happens, it certainly creates a situation where you can also talk about um, adding contrast or trying to enhance certain tissues. And if you can do that, then you can create a situation where pathology is more easily identified. Um, when we're talking about interpreting a chest X-ray, there are certain methods. Some people in the United States teach the A, B, C, D, E. It's just assumed that you start with the airway, you move to the bones, so you move outward. You make sure to evaluate the cardiac silhouette. Then you make sure to take care of the diaphragm, and then E stands for everything else. I much rather prefer the inside out method. The inside out method basically assumes that you start from the mediastinum and you work outward. So this basically just means that you won't hit an air, you won't miss anything. If you start outward from the mediastinum, the heart, and look at the lungs, then make sure that you're looking at everything in the chest wall, including the diaphragm and pleurum. Then hitting the ribs and making sure that you hit the subcutaneous tissues last. The subcutaneous tissues can be something that can be easily missed, and we'll have a couple of cases to show you why that's important. So the first thing you want to do when you take a look at a chest x-ray is make sure that it's an adequate study. Most people do this by just looking specifically at the clavicles, but then also at the spinous processes, making sure that they're vertical in the radiographic plane and that there isn't any rotation. If there is rotation, then you might start seeing angling of the spinous processes, or potentially that the clavicles are uneven, and I have some examples for that. Then there's a little bit of anatomy. You want to make sure that you're also trying to identify any major structures kind of within the actual mediastinum. After looking at the mediastinum, you want to look at the heart and make sure that the heart looks appropriate. It's a PA view, which this is, because you can tell that the clavicles are angled. Uh, Want to assess for cardiomegaly. And then you can work your way out to the lung fields. I usually start with the inferior portions of the lung fields because that's where pneumonia likes to hang out. I like to make sure that I can see the costophrenic angles. And once I look at the costophrenic angles, kind of evaluating the diaphragm, then I work up, make sure I don't see anything in either of the lung fields. Um, Once the lung fields kind of are in view and I feel like I've been able to actually assess them, um, I look at the bones and then I look at the subcutaneous tissues. It's really easy also to miss humerus fractures or even potentially clavicular fractures if you're not paying attention. So it's very important to look at the bones. Um, Starting with the hyla and then moving out. An example of a patient who has been rotated is this is a good example. You can see that the spinous processes are a little bit angled and that this clavicle is higher than this clavicle. With the patient's right clavicle being up, you can tell that there's a little bit of rotation. This patient just basically needed to be a little bit more, their right side needed to be down a little bit more. When you're talking about actually looking at the hilum and the mediastinum, there are a couple of lines to remember. Um, these basically are one dimensional representations of the trachea, the mediastinal structures, such as the great veins that are bringing back venous return to the heart, or even the esophagus. Um, And this is an example of kind of what I was talking about earlier is that you want to make sure that when you're evaluating the lungs, that the diaphragm is part of that assessment, and that the diaphragm is clearly laid out, and that you can see it clear and crisp. You want the diaphragm to be very, very flat and not flat, but curved, and it needs to have very sharp contour. If you look here at the picture on the left, the diaphragm is very, very sharp. And if you ever see blunting of the diaphragm, that usually implies that there's an infiltrate. So here are a couple examples of pathology. You can see here, this is a PA on the left, or I'm sorry, on the right. You can see that there's a PA view. You can tell from the clavicles. You can see, moving downwards that obviously there's an immediate mediastinal abnormality and some cardiomegaly. This patient actually has a pericardial effusion. You can tell that there's also an effusion of the left lung base, pleural effusion. And this patient has malignancy and presented with cardiac tamponade. On the left, there, this is an example of a tension pneumothorax. You can see here that the lung fields are pretty clearly made out. It's pretty easy to tell. Immediately, you might think that the patient is rotated because of their trachea, but the trachea and the mediastinum are all deviated away the from the tension pneumothorax and the tension created within the chest. You can tell the pleura is outlined here, and then you can tell over here that there's a diaphragmatic abnormality known as the deep focus sign, which just basically means that there's tension pushing downward as well as across. It's pushing down on the diaphragm. So again, we have a couple of PA views. You can tell because of the clavicles. Immediately, we can tell that this is an adequate radiograph, and our eyes are immediately drawn toward the mediastinal abnormality in this photo. This is what a widened mediastinum in an aortic dissection looks like. It's pretty clear that the patient, you know, has some degree of dissection just based off the fact that the mediastinum is basically widened, um, and uh, and also dense. You can tell that the density of the mediastinum is a little bit more. If you've seen enough of these pictures, the ability to look through the actual mediastinum is obscured basically by the density. This is a good example of a pneumonia. We see here that there's actually, you might think, well, yeah, that's a pretty easy pneumonia. I can see that. It's right here. But there's also an infiltrate on this side, and the reason that you can tell is because pleural, um, the pleural space on the left side has a little bit of blunting, and you lose the diaphragmatic contours. This patient, this circumstance, an AP radiograph, but you can also tell that there's a bilateral infiltrate. So basically noting that the infiltrate on the right side is present, but also on these are just a couple of examples of basically this is heart failure, and then here's pneumonia. Um, Pneumonia creates a little bit more of a density on the projection. Heart failure usually starts in the hyla, that works out. It's got a very specific pattern. People describe kind of like a uh, bat wing appearance to pulmonary edema. However, I will say that usually I don't really look at it that way. I look at it more that it starts centrally and that it works its way out. The way that that can be kind of appreciated is the fact that the hyla is a little bit more dense, but also that the densities in the ground glass that you can notice are more dense in the central portion than in the periphery. So you can tell specifically here that an infiltrate on the right is more dense peripherally. That's usually something that can be seen in pneumonia. It doesn't have to be seen, um, but pulmonary edema usually is more dense in the central portions of the hyla and the mediastinum and spreads peripherally um, rather than pneumonia. We can tell that some of these things are subtle. Here's a good representation of why a lateral view is very important. This is what pneumonia looks like on a lateral view. You can tell an infiltrate in the right middle lobe. Here on this, I think this is an AP presentation, you can tell that there's air underneath the diaphragm, which is really important to make sure that you always take a look at the subcutaneous tissues in the diaphragm, making sure that you don't just focus just on the lungs. If you focus just on the lungs, you'll miss something like this. And this is an acute pathology we want to make sure that we see. And then over here is just a subtle finding. It's basically just curvature of the diaphragm. You can tell there's a little bit of pleural fluid. Diaphragm should fall off like this, um, but instead we have a little bit of pleural fluid that's sitting there that's creating a little bit of a meniscus, a concave shape. On this side, the pleural is folding kind of like how you would expect, and it creates a little bit of an angle. Um, on the left side, you can tell there's a little bit of fluid that creates an opposite setup. Moving quickly onto ultrasonography, we want to make sure that ultrasound is considered for the chest, not necessarily just cardiac exam. When we're talking about the utility of ultrasound, it's really helpful in pneumothorax. It's really helpful for distinguishing pulmonary edema. It's really helpful for pneumonia. It's also extremely helpful for trauma and broken ribs. You can also evaluate the pleura quite well, not necessarily just a pneumothorax, but also um, evaluating for any pleural fluid that might be present. And this utility isn't just helpful in trauma. I use it a lot. Ultrasound is what we call a dynamic exam, which just basically means that it can be repeated. It can be trended when you're in the ICU. And it's similar to auscultation. It's very, very useful in the hands of somebody who has enough experience. If you've listened to enough lungs, then you can say confidently, there are crackles here, there are wheezing. Um, but it's really only dependent on the usability, and should be reserved for people who have comfort in it. But it is an extremely helpful exam. The way to ultrasound a chest is usually a 6 point exam. A 6 point exam basically implying that there's 6 points within the chest that you can actually evaluate. So there are two lateral, two anterior, and then two posterior in this. There are other people who just argue a 3 point exam, just basically evaluating an individual in the 3 planes, so anterior, lateral, and then posterior. Um, and that's fine too. Some people say, you know, you want to take a look at the apices and the bases. You want to make sure that you use the proper probe. You can use any of the probes, actually. You can use the curvilinear, you can use the linear, or you can use the cardiac probe. You just want to make sure that if you're doing it, you use the lung setting, because the lung setting is a very specific type of ultrasound that the machine is using and that the machine is actually sending into the lung. You also want to make sure that the patient is properly positioned, and that if the pathology that you're looking for is present, that the patient is positioned so that you will be able to actually see it. This basically means that you're looking superiorly for a pneumothorax for a patient who's sitting up, or if the patient has a pleural effusion, that you're looking inferiorly because the dense fluid is going to go to gravity. The air is obviously going to ascend, um, and yeah. So ultrasound of the lungs is an extremely helpful thing. It can potentially be a little bit more sensitive than chest X-ray. I'm not going to necessarily go into interpretation because there's a lot that goes into it. But very, very briefly, you know, the positioning of each probe. Here you can see the apical and base views laterally as well as the posterior windows. What you really want to look for when you're taking a look at the actual ultrasound of the lungs is you want to see A lines. The A lines are just horizontal lines that you can see within the plane. And that basically is just a reflection of the pleura. Air is extremely light and not dense, so it shouldn't reflect um, any type of ultrasound. It should just be reflected directly back, or at least a healthy line. So when the ultrasound is shot down, uh, the ultrasound machine shouldn't necessarily interpret anything. And when when it doesn't see anything, what happens is it creates an artifact called the A line, which just basically means that it's a double interpretation of the actual line that it's visualizing here. And it creates basically like a folded representation of the actual pleura that it's evaluating in an equidistant plane. So you can tell that if you looked at it with the ultrasound machine, that the distance from here to here is the same as the distance from here to here. And then ultimately the distance from there to there is also a symmetric field, if you will. Here's a couple quick examples of pathology. Over on the right, we can see some B lines, which are vertical lines. And this is basically what happens when the ultrasound hits fluid. You can see some of the lines actually project downward. And that's just basically a pocket of fluid that the ultrasound is able to capture and doesn't necessarily get reflected against. And so it's actually reading the return of the ultrasound when it hits that, and it creates a shadow effect. Pretty complex physics, and I'm not probably even explaining it to the depth that it probably deserves. But just know that you're just measuring density. So when you don't hit anything, you're just basically getting a reflection of the actual pleura, something called an A line. And then ultimately, when you hit density, you can measure things called B lines, but you can also measure, solid organ. This is what happens when you have a consolidation that's floating in pleural fluid. So a lot of complex stuff that goes into it. But you're really just measuring density the same as ultrasound, or the same as radiography, but just in a different way. So the interpretation is completely different. Moving on to CTs, I want to make sure that we kind of spend a little bit of thorough time on this, but I also want to make sure that it's kind of discussed um, in its right context. So CTs are usually reserved for sicker patients in the United States. Um, they're usually performed with IV contrast. They're usually held mainly for vascular pathology, but I will say that there's certain circumstances where a non-contrasted study would certainly also be indicated. We know from multiple studies that CT can improve diagnostic sensitivity of malignancy, of pneumonia, um, of pleural effusion evaluation, i.e., distinguishing empyema from simple pleural fluid collections. We know that it also improves rib fracture identification as well as vascular pathology. CT is an extremely helpful tool. Um, there are a couple different types. Uh, Non-contrasted studies are probably the second most common study that can be ordered, but this just basically assumes that the patient lays down and you get a CT. There's no IV needed. A CT with IV contrast basically assumes that you're giving a little bit of a delay to the IV contrast, um, and it means that you're evaluating tissues a little bit more thoroughly, and you're seeing where the blood flow goes. Angiography basically means that the contrast is still in the arteries or in the pulmonary arteries. Um, and I'll talk a little bit about what that is, and we'll show a little examples. The contrast basically is best used to evaluate either the lumens of the vessels or the blood flow. Um, and contrast is basically a measure of density based off of blood flow. Um, when you're talking about creating a density, you want to make sure that you understand that contrast is a hyperdense fluid that has iodine. In that when you're injecting it, you're trying to evaluate for the presence of inflammation or hyperemia. Um, and you want to time the contrast based off of your clinical suspicion. So, if, for example, here on the bottom right, you can see a liver that is non-contrasted. basically this is, a non-contrasted liver, so there's nothing necessarily injected into this liver, and you can see a very subtle lesion there that when you inject contrast receives blood flow. Now, this is the arterial phase, and you can tell because there's contrast within the hepatic arteries in this top right picture, as well as in the actual aorta, and the arteries are lighting up. In the delayed phase, you can tell that there are contrasted areas in the bottom right where there would otherwise be venous flow. So you can tell on the outside of a malignancy, there's a lot of blood flow. There's not a lot of blood flow necessarily within the malignancy because it's hypervascular. So when you delay the contrast, it might move away from more vascular structures because it moves through those areas very quickly. So you can tell that this is in the top right, a very arterialized and hypervascular hepatic cell carcinoma, which is it implies that it's more aggressive. The portal phase is something very specific for the liver, but just notice how the liver looks so much different when the contrast is allowed for a little bit of time to extravasate. The portal phase is just shot just a little bit after the arterial phase, and you can tell that because there's still contrast in the aorta. So, phasing of contrast is extremely important. And this also kind of implies that while X-rays create a static image, CTs can create a little bit of a more dynamic image and certainly add to differentials based off of when you're timing the contrast. You know, indications for a CT really depend on the clinical context, but it's really important to remember that CTs have more diagnostic sensitivity for certain conditions. The bottom right is an example of a patient who had a trauma and had a very, very subtle blunt trauma injury and had a very subtle pneumothorax that was otherwise missed on the x-ray, but was seen on a CT scan. Now, my argument for this is that the CT scan is helpful in identifying this, but it also creates an incidental finding where we're not necessarily concerned about that. Now, we will talk a little bit more about incidental findings in a later lecture, but it's important to know that CTs create incidental findings in the right circumstances and increase the rate of incidental findings. So it's really important to remember that while a CT is indicated to evaluate for certain subtle pathologies, cross-sectional images are better. The downsides are cost, radiation exposure, but also the fact that there are increased findings in the incidental findings. There's also this thought that unstable patients don't go to CT. I, while I do agree that this is something that I was taught, I do accompany patients to CT scanners all the time. If the patient's unstable, then you just need to be with them and you can monitor somebody who goes through CT. As long as you're able to be there and be with the tech, make sure that the tech is aware that the patient is critical. Then sometimes you just need to get that test. If you don't send any patient to the CT scanner because they're unstable, then you'll miss evaluating for whatever pathology you might be concerned about, and you don't confirm the diagnosis. So, interpreting a CT, basically the same as a chest X-ray. I work inward and then I work my way outward. Um, it's a little bit different though because there are different planes. So I usually start with the axial phase, and then I move to the coronal, and then the sagittal. The reason why is because the axial plane is usually the one that actually evaluates the mediastinum, the pulmonary vessels, the aorta, and the lung fields best. And these are kind of the things where um, pathology happens. You can see certain things like the lobes of the lungs better on the coronal field. You can also probably see the diaphragm a little bit better on the sagittal field. Um, and you can see uh, some of the aorta a little bit better when you take it sagittally, but it is better to start with the axial plane. So an example of a CTA, this is a normal CTA here on the left. What you can see is you can see somebody scrolling through the axial view. This is what I usually do is I usually start on the axial plane and then just go through. Um, you're looking anteriorly, so this is the anterior surface, this is the posterior surface. You're looking as though the patient is laying down with their feet towards you. So this is the patient's right, this is the patient's left. You can see the liver down there at the bottom um, towards the end of the projection, and then you can see the spleen on the left. It's a very good example of what a normal CTA looks like. The aorta is normal caliber. Um, the pulmonary vessels are seeing a little bit of with a little bit of contrast in it, but the timing is clearly aortic um, to try to basically evaluate for any aortic pathology. Here in the bottom right, you can see the sagittal view where you can see the spine and you can see the aorta in its detail. You also see the bases of the lungs and the diaphragm. Um, and at the top right is a good example of the coronal, which is just basically a representation of an AP or a PA radiograph, um, which allows you to evaluate obviously more detail, especially with contrast. You can discern the vessels in greater detail. Um, Also discern how viscous organs in the abdomen, like the stomach. Um, you can evaluate subdiaphragmatic things like the liver. Now remember, you see things that are a lot better, but so this will increase your findings of incidental things, and you just need to remember that. And we'll talk a little bit more about incidental findings at some point, because that's a good topic to overview. So we talked a little bit about contrast timing, and here is a good example of what a PE study looks like. The contrast timing is put in so that most of the contrast is actually in the right heart. You can see that the bolus of contrast does make it to the left ventricle too, down here at the bottom, right here. But you can tell that the majority of the contrast is actually focused in the right heart. You can see it in the pulmonary arteries. Down here at the bases, you can also see that the patient has a couple of pleural effusions. Uh, that's kind of the incidental finding. You can see that it's dependent. There's a little bit of dependent atelectasis around those lung bases as well. So difficult to say whether or not this patient has heart failure or not, but the heart looks a little bit large and there's certainly some fluid in the dependent portions. Here's a good example of a CTP sagittal view. Again, you can see the spine really well with the sagittal view. You can also see the heart. You know, see the basically the mediastinum kind of in a lateral aspect and sagittal aspect. The coronal representation creates a good representation of the patient's chest as it would be otherwise seen in a PA or an AP radiograph. And here in this certain example is a good example of what embolus looks like. You can see a big P that's limiting the contrast flow from the right heart. So when you're doing a CTPE projection and you're creating a sequence that's meant to evaluate for pulmonary embolism, um, there's also a certain type of study that you can create called maximum intensity projections. I'm not going to spend a lot of time on this, but just know what it is when you see it on the actual CTs. It creates a representation of basically the most dense um, measurement from multiple projections and then lays it on top of each other. So this just basically creates a projection where the iodinated contrast is projected in a long plane. You can see this here kind of on the bottom right, where you have a single plane of basically like a CTPE study and how you're just looking at the vessel in one plane. When you take a MIPS projection, you're taking 3 to 5 pictures and putting them on top of each other. So you take a look at basically like a blood vessel or the highest intensity area within the actual projection um, over a couple of pictures. So you're taking a look at a larger part of the vessel, if that makes sense. So it's pretty helpful study for stroke as well as PE. Um, there's also windowing. Um, CTs can get pretty complex pretty quickly, but I'll talk a little bit about windowing. But here's a quick example um, of a non-contrasted CT. You can tell that there's no contrast in the aorta. You can also tell that there's no contrast in the heart. The aorta just looks dark. It looks dense, similar to the heart. The blood vessels look similar density to the soft tissues like the liver. Uh, None of the pulmonary arteries are lighting up, so you can't discern what's lymph tissue, what's soft tissue, or what's what are blood vessels in this. Um, and That's part of the limitation of a non-con, but you can still see the actual lung fields pretty well. And you can see them comparatively to like a chest x-ray, you can see them quite well. Um, so this is why a CT is helpful in evaluating the lung field. What I will say though is that there's an increasing frequency of incidental findings, specifically in CTs of the chest, where you see lung nodules. And we can talk a little bit more about kind of what a concerning lung nodule is, but just know that something less than 1 centimeter is usually benign. Doesn't necessarily mean that it needs follow-up. Um, when you don't have any contrast for a CT scan, a lung nodules are very common, and a lung nodule won't necessarily enhance or take up any IV contrast if you do the CT chest with contrast, but a lung nodule will basically look like a very small um, dot that you'll only be able to see in a very small plane. And it'll come and go and it will look different than a blood vessel. So this is an example of what windowing means. Windowing basically means that you're focusing on a specific type of tissue. You can focus on a number of different tissues. There's a way to focus on soft tissue. There's a way to focus on bone. There's a way to focus on lung. Basically, what this means is that the actual density is just being messed with, for lack of a better word. There's something called attenuation. And attenuation basically means that the the gray scale, or the area where we actually see things as either gray or black or white, is either narrowed or widened. Usually, a specific type of window is a narrow window, um, and the width is basically narrowed, which basically means that the grayscale spectrum is focused to look at a very specific tissue. What this means is that you will get specific types of pictures from the same image. Now, these are all the same images. This is a CT scan with the same amount of data, and you're focusing on different things. you're focusing on either the bone, the lung, or you're focusing on soft tissue, which is why you can see the heart a little bit better on this picture. Um, those are kind of the three basic windows of the bone, lung, and soft tissue. For simplicity's sake, I would just kind of remember that that's kind of how it is. But there are definitely different types of windows, especially when you're talking about different types of CT scans. And it basically just means that you're seeing things differently. So when you look here, this is actually a soft tissue window for this non-contrasted CT. When you come back over here, this is actually a lung window. And you can tell that because it's just whiter on the screen. So the attenuation is higher. This is also a contrasted study as opposed to the other study, which is non-contrasted. And you can tell that because there's contrast inside the the humongous pulmonary artery here. This is a good example of right heart strain because the patient here has a significantly large pulmonary artery, but the right heart is also much larger. You can tell right there than the left heart. You can also tell that there's pulmonary edema throughout the lung fields. I'll show you a little bit about what a normal lung field looks like, but there's fluid throughout all of the lung. And it looks symmetric. It also looks like it is worse kind of centrally and then spreads peripherally. You can tell that it creates little pockets. And it's just basically the fluid accumulating in the alveoli. So a couple examples of pathology on CT scans. Um, we talked a little bit about kind of a lung window. So this is a lung window study. You can see here that there's outline of what looks like an infiltrate. Um, this is normal lung parenchyma right here. The lung should be aerated and it shouldn't necessarily be dense. Once you start seeing density like this, you get a little bit concerned about pneumonia. Pneumonia can look exactly like this, and it can outline like that. It can also just basically collapse the lung and look like this too. Um, Here we see basically a linear kind of infiltrate. This is also a good example of what pneumonia can look like. Again, normal lung tissue out here. But as soon as you start talking about some density is picked up or appreciated in the lung window, then you're a little bit more concerned about pneumonia. Here in the central part, we're looking at what a pneumothorax looks like on CT. You can tell that the pleura basically has collapsed in relation to the chest wall. Um, that's a good example of what a pneumothorax looks like. It's just basically empty space. You'll see loss of the lung markings. You can see all these small blood vessels and all this, less dense normal lung tissue. Um, when the when the lung falls, then you obviously just have loss of that. You just have empty space here in this vacuum. Um, really quickly, this is what a broken rib looks like on a CT scan. You can tell that in all of these, this CT, this CT, these are all windowed for lungs. This study, this study here is windowed for bone, which is why you're seeing the bone a little bit better. And I know that it's kind of difficult to describe. It's a little bit darker. It's less white. The grayscale is turned down a little bit. So it's looking at more dense things, as opposed to lung windows, which are looking at less dense things. Um, the bones themselves are evaluated a little bit better in this window, which is why it's called the bone window. And you can also see fractures better. In the bottom right, you can see a specific plane of fracture. where you can see the fracture from different angles. This I just included this because it's a good example of what fractures look like at different angles. And we talked a little bit about evaluating for subcutaneous tissue. If you look at a fracture, you want to also make sure that you look at the subcutaneous tissue because sometimes patients can have subcutaneous emphysema. And if that's the case, then they might have a hemothorax or potentially a pneumothorax. There you can see the hemothorax or the pleural fluid. Moving on to like arterial and vascular phenomenon. This GIF up here is a good example of a pulmonary embolism. Here in the top left, you can see what a PE looks like without contrast. Very, very rare that you would otherwise see it without contrast, but under the circumstance, you can kind of pause the image. It's much more subtle. When you add contrast, though, it becomes much more illuminated, it becomes much more obvious. Um, and basically shows that there's a filling defect within the actual pulmonary artery. This creates a shadow basically, and basically a lack of density within the blood vessel because the iodinated contrast is going to go past the area where it can fill. It's not necessarily going to be absorbed or appreciated in the clot. So you just see these small hyperdense foci inside the blood vessel instead of seeing the contrast extravasate. This last picture down here is just basically a good example of what right heart strain looks like. The right ventricle obviously sits more anteriorly in the chest and should be smaller, more collapsible than the left ventricle. I know we all know that. And so when you're talking about how big the left ventricle should be, you want to measure from the actual mitral valve over to I'm sorry, you want to take it from the tricuspid valve and then measure across to the mitral valve. And anything above a 50-50 ratio in the right heart is suggestive of right heart strain. And you usually do this with axial view. So this is a good example of what right heart strain is. I think this is kind of the last slide. And I know that this was very quick and maybe brief in terms of what we could potentially talk about in terms of actual chest imaging. But hopefully it serves as kind of an introduction and we can follow up on questions. Please let me know on the WhatsApp if there's anything else that I can potentially talk about um, in terms of following up any uncertainties about this lecture. Because I know it's complicated. The last thing here is just basically the angiography studies timed for arterial sequences. So you can see here basically an example of a subtle aortic dissection. Right here is the dissection flap. Um, this is basically not good. This patient's probably hypertensive. They're probably in a lot of pain. They probably have chest pain. 80% of people with dissection present with chest pain. And you can tell that the dissection flap is basically creating a little bit of pressure. The aorta is going to push the blood pressure down underneath that flap and then eventually create what we call a false lumen, which is seen here. This is a more severe dissection. This is a type A dissection that would require surgery. Here on the right is a view of what could be a type A or a type B, but the type is it doesn't it depends on anatomical location. But this is a severe dissection over here because you can see a humongous false lumen. The lumen of the vessel is basically separated out, and that's what a dissection flap looks like. So we'll try to kind of return to this at some point. Chest X-ray is a useful test. It's a very useful test. Um, and respiratory evaluation, not test. It can improve diagnostic accuracy. It's been surmounted by the CT as something that can improve patient care. It is a best first test for a patient who's unstable. Um, and a portable chest is certainly something that I would always remember to try to reach for if you can. Um, it improves diagnostic sensitivity and specificity. It doesn't necessarily require a whole amount of resources like CT scan or ultrasound. Ultrasound is my personal favorite. I would say that if you could learn any skill to evaluate chest pathology better, it would be ultrasound. In my mind, ultrasound is a little bit better than CT. The reason why is because it's a dynamic exam. You can repeat it without cost or radiation. And you can also use it on the heart. So we'll talk about this at a later lecture, but it's a helpful tool to have for shock, cardiac conditions, and assessing volume. So when you put everything together with an ultrasound probe, it's just a better tool. Um, and we can talk a little bit more about kind of how that all comes together. But CT is kind of the evolving tool. It's certainly something that's become more widespread. I know that it's there at Celiani. It's becoming more available at certain Tanzanian hospitals like Meru. Um, and it certainly does evaluate cytopathology a little bit better. It increases incidental findings. So just know that if you see incidental findings noted on a radiology report, that's something that happens with CT, and we know that has increased lifetime cancers across the United States um, because we've been irradiating people more, mostly because of incidental findings. If you want to do a little bit more additional reading and learning, um, I've provided a couple resources in this. I haven't decided what the next topic is. I wanted to reach out to you guys and kind of figure that out. I promise that this month I will actually work on putting these videos on YouTube and making sure that they're situated on the KOPI channel. And as soon as that happens, I'll hit you guys up on the WhatsApp. Um, but for now, if you want to just read a little bit more about actual chest imaging stuff. There's this thing called Radiology Masterclass that walks you through how to interpret a chest X-ray. I know we've talked about radiopedia and prior things. There's a Society for Academic Emergency Medicine, which stands for SAEM, which is an American organization that talks a little bit about how to interpret a chest X-ray. And then if you want to learn a little bit more about ultrasound, there is an ultrasound website that I've put in this as well. Um, I'll make sure to get this out to you guys. Okay. So let's meet up in a month. I didn't even put the date on there, but we'll talk sometime in January, last Saturday of the month, and I'm happy that this came together and that we were able to talk this December. Hope everybody had a good Christmas. Um, Let me stop recording real quick, and we can take quick questions, and then I have to shuffle off. Any questions about that right now? I know you guys are all muted and don't have the best connection right now. It's okay if there are questions. I got to get to my shift here soon, so maybe if there are any questions, Clement, you unmuted yourself. Dr. Ari, how are you?
I'm good.
Good.
All right. Thanks for the very good presentation. Um, it's actually comprehensive and I've learned a lot. But I have a question which is not like straight, it's not all about what you have said, but it's something that has been like confusing me, like
Hmm.
what to do, because apparently we have like this technology of artificial intelligence. And it seems like most of people, especially the medical personnel, the doctors, they are employing artificial intelligence in terms of diagnostics.
Hmm.
So when it comes to condition that needs like investigation, like chest X-ray, CT scans, I've seen most of people trying to use artificial intelligence in terms of interpreting the results of the imagings.
Yeah.
So I don't really know how effective and how accurate the responses from the AI are in terms of the results from the chest X-rays or CT scans. So I was asking, how often do you guys use artificial intelligence in terms of interpreting these results of the imagings?
In the emergency department, I never use it. I know that the radiologists are starting to use it as a backup, but I would never rely on it wholeheartedly. I would never like trust it over my clinical interpretation.
So for us juniors, would you like advise?
I mean, I think that it can be used, Clement, to kind of aid your diagnosis, and you can use it to kind of help guide, like, you know, it's really good at like incidental stuff. So, like, if you see something that isn't um, isn't necessarily something that you're focused on. But usually I'm ordering a test to answer a question, and I want to see exactly whether or not that question is answered. So the AI models don't necessarily do a great job of that. The AI model just basically creates a representation based off of what you put in front of it, right? Like it doesn't have a pretest probability. So, it's going to take a lot of work. It's going to take a lot of technological advances before an AI model is as good as you at discerning and determining, whether or not your question is answered based off of your test, if that makes sense.
Sure, thank you.
Yeah, for sure, man. I gotta run, guys. I need to get just I need to get my stuff ready for my shift. I gotta leave here in a couple minutes, but it was good to see you all. I know that this was it was tough to make this one just because of the timing and because of the rain, but I'll be in touch really soon. I promise about the videos. I've been horrible about that, and I promise I'll actually do a little bit of work with Dr. Nathan to make sure that they make it to the website and that they're actually available to you guys because I feel bad that that hasn't happened. Um, and I'll be in touch about January's topic. I want feedback from you guys about what you'd like to hear about. So good to see everybody. And